So let's go ahead and get started because we have a lot to cover today. Second, make sure my lights are on. Maybe we can get the lights back on in here. Otherwise, I don't want anyone to fall asleep. There wasn't any coffee. All right. Yay! And let there be light. All right. Hi, everyone. My name is Tulsi Modi. I'm a senior project manager at the Planetary Health Alliance. And today we have some incredible speakers lined up for you. And before getting out here, I was like, man, I should really tell a joke or something because it's been so funny today. So this is what I have for you. I not a knock-knock joke, I promise. I talked to my parents, on my commute to and from work. And I was telling them about this conference, and they're like, so, like, what do you do again? And I'm like, oh, okay, so let me tell you. I got really excited. I'm like, so, Planetary Health is this like transdisciplinary, thing that we're working on. And you see like the confusion and the silence on the phones, and you're just like, all right. And then inevitably, every time someone, usually my mom, will be like, you could have been a doctor. You could have saved lives. What are you going to do now? Save to PDF? And I was like, yes. But we have 4 doctors here today who can do both, which is great. So we have Dr. Leo Trasande from NYU Langone, Daniel Rosenberg from NRDC, Jeremy Greene from Johns Hopkins, and Hardeep Singh from the Baylor College of Medicine. So I'm going to let them introduce themselves, and we'll jump right in. Okay. Leo, to you.
I don't have slides today. There's the mic. Okay, great. Good morning, everyone. So allow me to connect all of the previous discussions first and foremost with plastics. Plastics are byproducts of fossil fuels. Whether it's oil or gas, you're making either ethane or propane, you're cracking it into ethylene or polypropylene, and then you're polymerizing it because that's what plastic really is. It's a polymer. Polyvinyl chloride is made by further modification of ethylene into vinyl chloride and then polymerized on its own. So when we think about plastics, we have to keep that in mind, even if under certain circumstances, we might emphasize it more or less given the political winds. But suffice it to say that plastics are an exponential and emerging threat. There are 3 pauses in the exponential growth of plastic production. The 1970s oil crisis, the 2008 financial crisis, and the 2020 COVID pandemic. With those exceptions, there has been a constant and inexorable rise in the production of plastic. In fact, the BRIC countries, Brazil, Russia, India, and China, and some of the lower and middle income countries are seeing this along with the fossil fuel countries and companies, are seeing this as an off-ramp, as emphasis on climate change towards reducing fossil fuel burning is towards diverting the byproducts of fossil fuels into other products, ultimately. So this is the global tension that we have as we focus increasingly on the concept that burning fossil fuels contributes directly to temperature. So I'm going to focus on 3 direct health consequences of plastics, ultimately. I'm going to focus mostly on the direct effect of chemicals and micro nanoplastics, but I would be remiss if I didn't focus on the broader picture of there being a triple planetary threat and triple threat to human health. So it's obvious perhaps, but plastic is everywhere in waste in our lives. And plastic has ultimately found its way into our ecological systems. And that, literally harming nature has made it impossible for us to feed more directly ourselves as a planet. I'm not going to be able to go into the deeper aspects of it. We know that particles, you've seen the straw in the sea turtle, you've seen the microscopic effects of micro nanoplastics in wildlife, and then they're more invisible effects. We also know that plastics contribute directly to climate change. We are not going to achieve 1.5 C without changing the exponential growth of plastic production on our planet. And microplastics in the sediments of oceans prevent the ability to sequester carbon dioxide. So thereby you have consequences for heat and all of the things that you've been talking about during this conference thus far. But I'm going to now shift gears and really hone in on the effects, first, of chemicals used in plastic and micro nanoplastic. But let me explain the chemistry first and foremost. So when we're talking about micro and nanoplastics, we're talking about different lengths of polymers breaking down and getting into various levels of visibility, ultimately. And the micro and nanoplastics have our biggest attention as a public because they're visible. But we need to be as curious about the invisible as the visible. And that's really where I'm going to focus the majority of the presentation, because micro and nanoplastics are really an emerging field. I think there's some lack of agreement about how to measure microplastics and nanoplastics around studies. The famous study that has brought this to the fore as a human health issue is the New England Journal of Medicine finding that microplastics and nanoplastics, particularly polyvinyl chloride and polyethylene materials, were associated with a 4-fold increase in the composite outcome of heart attack, stroke, and death. But we're still a long ways from being able to understand whether it's the abrasiveness of plastic in the human body, literally wrecking tissues, or the drug delivery systems that they recommend and represent. And in this case, I'm talking about the toxic drug delivery systems. I'm making that rhetorical comparison here because we do use nanotechnology for good in human health. And I'm not minimizing. As a pediatrician, I've intubated babies, I've used plastic, we treat patients with chronic kidney disease with dialysis. We give nebulizer treatments with asthmatics. It's a bit awkward in the health profession community to talk about plastics because we use plastic for benefit, but that's essential plastic in the current state of play. We need to focus on minimizing the non-essential use of plastic that have led to that inexorable increase in the use of plastic production and consumption. It's that unnecessary plastic that we need to really focus and hone in on. There's a lot of low-hanging fruit there. But the biggest scientific evidence to date is about literally the chemicals used in plastic materials. Sometimes they're additives to plastic. Phthalates are used to soften polyvinyl chloride, used in personal care products, cosmetics, and food packaging. We're talking about bisphenols, a monomer of polycarbonate plastic that are used in aluminum can linings, thermal paper receipts. We're talking about PFAS, per and polyfluoroalkyl substances that are increasingly used, by the way, in fluorine polymer chemistry. They're in the linings of nonstick cooking pans and oil and water resistant clothing. And increasingly, phosphorus flame retardants are replacing brominated flame retardants that have largely been phased out. But they themselves are added because I don't want my iPhone to burn up. I understand that, but there are consequences to the broader and widespread use of flame retardants that end up in dust, water, food, et cetera. Now, these are all known as endocrine disrupting chemicals. These are chemicals that hack our molecular signaling that underlie basic biological functions to humankind: temperature, metabolism, salt, sugar, and even sex. These chemicals are extremely well established in laboratory and animal studies, matched with human epidemiologic data that show substantial convergence and consistency. The effects run from cradle to grave, from womb to tomb. I'd like to thank Senator Frist for supporting, through the Children's Health Act of 2000, the National Children's Study, which is now rebranded as the Environmental Influences on Child Health Outcomes Program. In that study, we found that phthalate exposures across the country were associated with roughly 5 to 10% of premature births in the United States alone. That's roughly worth $4 billion in additional medical care and long-term lost economic productivity as a result of reduced IQ. So these make babies get born earlier. These shrink babies' growth. Intrauterine growth restriction sets up a thrifty phenotype that sets the child up for being an adult who's obese and ultimately develops cardiovascular disease early on in life. We know that these chemicals used in plastic materials literally shrink brain development in utero. The baby relies on thyroid hormone from mom through the second trimester of pregnancy. And in the clinically normal range, this isn't unfortunately something an obstetrician can detect, changes in thyroid hormone function in utero can produce cognitive deficits and even autism and attention deficit hyperactivity disorder. So I've already alluded to some of the potential consequences from metabolic disruption through programming. In one study that measured serum levels of PFAS after a healthy diet and physical activity intervention, these are adults who lost weight successfully, the PFAS levels were associated with regaining the weight back. So nothing I'm talking about here mitigates the importance of diet and physical activity. It's just there are 3 legs to the stool, not 2. And we also know that these chemicals impair fertility. They reduce the anogenital distance in boys, which is a marker of sperm count and ultimately even cardiovascular disease in later life. This is in relationship, again, to phthalate exposure. And ultimately, these chemicals contribute to cancer, reproductive cancers in particular, endocrine-sensitive cancers, thyroid, testicular, as well as breast and ovarian have all been etiologically linked. Now, I'm going to empower you with some statistics that will also help provide the policy context in this tough US climate, which is that plastics also harm our economy. The costs of disease and disability due to chemicals used in plastic materials alone is $249 billion a year. That's 1.2% of the gross domestic product. Mind you, the plastics industry only makes $750 billion in global revenue annually, and yet it's on the backs of $250 billion in disease-related costs. So last I checked, this is a pretty poor business model. So I'm going to boil this down because I'm probably already getting the hook. So there are safe and simple steps we can all take to reduce exposure that don't require a PhD in chemistry. They don't have to break the bank. I know we'll talk about policy steps that can be taken to reduce exposure. So I'll hold my comments in that space. I'll mention the Global Plastics Treaty in the UN context as a great opportunity to further support what might not be able to be done in the United States presently. Though I do hear the Secretary of Health and Human Services is very interested in microplastics and PFAS, to be clear. But reducing our plastic footprint can reduce chemical levels in days. And this, again, was successful in intervention studies in low-income as well as in high-income populations. And there are short, medium, and long-term consequences. Urinary levels of bisphenols and phthalates dropped 30 to 60% in 3 days. And that's because most of these chemicals have short half-lives. If you sustain those interventions over the medium term, you also change hormone levels in medium term. And then if we continue and sustain these interventions in the longer term, we'll have an opportunity to reduce chronic diseases and disabilities like the ones I've mentioned. Now, I want to close with just the final comment. Some will say, well, this isn't mainstream science. You have the Endocrine Society with 2 scientific statements. The World Health Organization, United Nations Environment Program is actively writing its 2nd scientific statement, which I'm involved in at the present time. The International Federation of Gynecologists and Obstetricians and the American Academy of Pediatrics, as well as the World Obesity Federation, which emphasized the need for policy actions to limit chemical obesogen and diabetogen exposure. So thank you. I look forward to the other panelists.
Okay, thank you. My name is Daniel Rosenberg. I'm the Director of Federal Toxics Policy at the Natural Resources Defense Council, NRDC. I was a doctor for a minute when you promoted me to a doctor, but I'm only a lawyer. So I don't know if, I don't know, my parents would have been so proud to hear me become a doctor today. Totally worth it to come for that. I have been working on toxic related issues for about 30 years here in Washington, D.C. And so I'm going to kind of talk about the current context of plastic health and climate in Washington, D.C., which generally things are going pretty good here. I think you all know that, nothing to worry about. So I'm going to give you just a little more bad news as sort of an icing on the cake that we've all been eating, not to presuppose where everybody feels about the state of the world. So as Leo said, plastic production is expanding, and there's a movement there's good news within this talk. The climate movement has been successful, the anti-climate movement, in getting reduction in fossil fuels in key areas, including vehicles and buildings. As fossil fuel use is going down in some places, the industry needs other markets to direct their fossil fuels. And as Leo said, one of those is plastic. So although there's an effort, including the Global Plastics Treaty and state level actions and within various sectors, people to use less plastic, the industry is actually projected to triple plastic production and plastic waste generated between now and 2060. So we're already at a global plastic crisis level. And if the industry has its way, and they're very candid about this isn't like a conspiracy, they have testified to this, they want to triple their production. So that's a problem. The industry also knows that it's facing, regulation at the state level, regulation at the federal level, regulation at the global level, people using their dollars to not buy plastic, not buying plastic water bottles, et cetera. So they've come up with a way of, and they've done this before, but sort of a way of spinning what they're doing to make it sound green and healthful in order to avoid regulation. And so what they have been talking about, maybe you've seen this or heard this on ads, on I think TWA, they were running ads. They're talking about a circular economy for plastic, which is nonsense. And they're talking about chemical recycling. So they're talking about recycling plastic. Chemical recycling is a term you might have heard. They also call it advanced recycling and molecular recycling. Those are all greenwashing terms invented over the last few years to refer to what is essentially burning plastic, using incinerators to burn plastic. So what the industry says is, well, we're going to create a circular economy of plastic. So no need to control or limit how much we produce because we're going to recycle it all, and recycling is great. So what they're actually doing, there's a few different technologies, including breaking down plastic with solvents, which is super toxic. But the main one is using pyrolysis incinerators to convert plastic into what's called pyrolysis oil. It's actually kind of a toxic sludge. And then refine that, mix it in with regular fuel to make fuel derived from plastic waste. So you might have picked up that that's not actually recycling. If you take plastic and you convert it into highly toxic fuel, that's not recycling. So if you look at their language, the industry will usually say things like, well, we believe in a circular economy of plastic so that we can recycle and reuse and repurpose, they have some other recycle, repurpose, and something else. The other two things are not recycling, and that's what they're actually talking about. So in order to do this, there's some limitations on the industry's ability to do this. So they're projected to build 2 or 3 dozen of these plastic incinerators throughout the United States. And when I say throughout the United States, primarily in environmental justice communities, just to be clear, that's where these incinerators are being built. So if you burn plastic in an incinerator, what happens? Well, you get toxic air emissions, highly toxic air emissions, hazardous air pollutants, metals, PFAS, all kinds, anything you can think of that would be in burning plastic. As Leo said, plastic contains a lot of chemicals, a lot of different chemicals depending on the type of plastic. So those chemicals don't go away. If you burn them, they go up some of it goes up in the stacks as hazardous air pollutants. Another product of pyrolysis of plastic is hazardous waste. These incinerators generate large amounts of hazardous waste, and that hazardous waste has to go somewhere. It's shipped or trucked or wherever to hazardous waste landfills or hazardous waste incinerators, but there's hazardous waste that needs to be disposed of. So it's not clean or green. And then the third thing that happens with this, like I said, most of it is being turned into fuel, and that fuel itself is highly toxic. So when it goes to refineries, people living near refineries are going to be breathing in, and then the toxics from that. And then when it's used in fuel, jet fuel, boat fuel, whatever kind of fuel, we're all going to be exposed to it and breathe it or ingest it or whatever. So just quickly, there's the thing that's going on right now in Washington, and it's actually going on in the states too, but I'm just going to focus on the federal. We can talk about states later if people want to. The industry is very organized and mobilized, and they are trying to get out from under regulation of 3 main federal statutes that somewhat control pollution emissions, require monitoring and public notification of pollution that's being generated, and that require the companies to internalize at least some of their costs. They're not internalizing a huge amount of the cost. That's the health costs we're bearing from plastic, but they have to internalize some of the costs now for pollution. Okay, so the Clean Air Act regulates emissions from incinerators. The Resource Conservation and Recovery Act, RCRA, or it's also called the Solid Waste Disposal Act, that regulates hazardous waste. And then the Toxic Substances Control Act, TSCA, is something that limits the amount of chemicals that can come onto the market. EPA is supposed to review new chemicals before they come onto the market, determine if they pose an unreasonable risk to human health and the environment, and if they do, impose restrictions on those. All the new chemicals and fuels that are made from this result of pyrolysis are new chemicals that have to go through the TSCA program. So the industry is right now both through EPA, which has been taken over again by chemical industry lobbyists, and through Congress, which has also been taken over by chemical industry lobbyists. They are looking both through legislative means and regulatory means to remove the regulation of plastic incinerators under the Clean Air Act, to remove the regulation of the hazardous waste generated by incinerators under the Solid Waste Disposal Act, and to basically remove the effective protections under the Toxic Substances Control Act that would require EPA to prohibit or basically prohibit the production of these highly toxic fuels. So I'm probably close to my time, but I just want to say we can talk more, but
is this going to take long?
any work that can be done to reduce the use of single-use plastic that I'm talking about is super important, and it's particularly important in the healthcare field. And I recognize that not all single-use plastic is ready to be substituted or eliminated in the healthcare field, but some of it is or can be. And it's important for a couple of reasons. One, any reduction in single-use plastic is critical because it's making less plastic, and it's going to counter the plastic business model that Leo was just talking about. And second of all, the healthcare community is so important as a symbol of expertise and health and credibility in Washington, in the states. And so if you all are seen as moving away from single-use plastic, it has a significant magnifying effect as far as policy. And the industry likes to point to the needs for plastic in healthcare. It's one of their lobbying talking points. Well, we need plastic in healthcare, so we shouldn't be doing any regulation or limiting of plastic pollution, whatever their spiel is. So yes, some plastic in healthcare, but not all of it. And the more you guys can be leaders in getting out of that, that's going to help counter the industry talking points. And lastly, by reducing plastic production, in addition to stopping all this toxic pollution that harms our health, it will also help reduce the climate crisis, because the production, the whole life cycle of plastic also leads to, as I think you already know, contributions to climate crisis. Thank you.
Thanks so much, Dan. I'm going to stand here just so I can see some slides, but it's such a pleasure to be with you here today. I think Dan set me up nicely to shift us from talking about them to talking about from a they to a we, really. So my name is Jeremy Greene. I'm an internist. I see patients at the East Baltimore Medical Center. I'm also a historian. I direct the Institute of History of Medicine at Johns Hopkins. I hope to convince you these two things work together in very important ways. If we could have the slides, I'm not sure how to make them appear behind me. Maybe that'll do it. Okay, wonderful. So so some of you may recognize this image. It was from last summer. At the end of last summer, all beaches in the state of Maryland were shut down when thousands of syringes and hypodermic needles washed ashore. You know, no one knew exactly where they came from. They were clearly agreed upon to be a biohazard and a threat to health. It only lasted a little bit of time before it all got cleaned up, but it evoked to me, as a practitioner in Maryland, an event that had happened back in the late 80s. A similar thing happened in 1987 when thousands of hypodermic needles washed ashore on the shores of New Jersey at first and then went down as far south as the Carolinas, as far north as Massachusetts. It started a national crisis over medical waste, and in fact, introduced the term medical waste into common usage in federal regulation. And so I want to talk a bit about how we think about the ecological consequences of healthcare, but particularly in plastics. It's a bridge between the last panel and this one. Another way of looking at this is a set of events that also happened last year. There's the largest environmental crime settlement in the history of the state of Maryland when the incinerator the Curtis Bay Energy Corporation, which is the largest medical waste incinerator in North America, received a fine for improperly burning at low temperatures in which more toxic compounds are released into the environment, medical waste, some of which coming from my own institution, Johns Hopkins. And we faced quite a reckoning at Johns Hopkins and managed to divert all of our materials away from incineration, especially from Curtis Bay incineration. We can talk more about that later. But I learned about this mostly through the action of environmental justice activists in South Baltimore, specifically the South Baltimore Community Land Trust. Now, Curtis Bay is also a neighborhood. It's the neighborhood with the highest rates of asthma in the city. And these two things are not unrelated. So how do we deal with the fact that we produce a disproportionate share of waste associated with plastic devices, that this particular connection actually comes back immediately into our healthcare institutions, harming the communities that we are tasked to serve? So I want to look at healthcare plastics simultaneously as threats to health and healthcare plastics as key to healthcare. And I'd like to talk a bit about how we got hooked on plastics in healthcare and what we can do to reevaluate this situation. Now, I don't mean to suggest that plastics don't do anything useful for healthcare at all, right? But I do think that we have overvalued our dependency on single-use plastics, and the time has come to reset that reckoning. This is part of an 8-nation comparative study that I'm taking in part with folks really around the world trying to do a similar process of bringing the dependency of single-use plastics in healthcare to light and questioning what happens after their single use. Now, I highlight here the Plastipack syringe, not because I want to single out Becton Dickinson as a particular company, but Plastipack syringe became one of the biggest symbols of shifting towards plastic disposable measures in the 1960s as representing key virtues in healthcare. And I can take you through a whole literature that emerged in the 60s about the virtues that disposables brought to medicine. Not all disposables were plastic, not all plastics were disposables, but these two things quickly became cinched in the eyes of hospital administrators and managers and healthcare organizations. And again, just to underscore that we actually need industry partners in rethinking alternatives to plastics. So I'm not trying to throw Becton Dickinson under the bus here. And what I want to say is look at this advertisement from 1958, which advertises disposables or reusables. Like, which do you want, hospital manager? We will provide either to you, right? It all depends on where the demand lies. And at this point in time, disposables were more expensive than reusable items because we had the infrastructure in place throughout healthcare to sterilize, reuse, autoclave. So what I'm trying to say here is this is an us problem, right? We became dependent on single-use plastics, and we need to be able to critically reevaluate them. Now, I want to say 3 things about this. There's 3 key virtues that single-use plastics offered to healthcare starting in the 60s and then amplifying in the 1980s. So what happens when medical waste becomes codified in the 80s is the rise of single-use products grow exponentially more so as we become increasingly, not only do we justify that, but we naturalize and we've valorized disposability as something that is a necessary virtue in healthcare. So safety, and of course, the plastic hypodermic syringe has done tremendous things to decrease the rate of nosocomial infections, of the spread of hepatitis, HIV, AIDS, right? So there are some real virtues that the single-use product has brought to healthcare. We could talk a bit about elements of efficacy. And the single-use syringe had a sharper point because it didn't get dulled between uses. We could talk about efficiency, right? Because at a certain point, and that point's roughly 1968, they started to become cheaper. But why did they become cheaper?
It became cheaper because there was now volume interest in purchasing among healthcare institutions, right? So there was nothing natural about a single-use plastic medical device that made it cheaper. It became cheaper when markets were driven by purchasing actions. So here we see these presumed value conflicts between sustainability and safety, right? We're not going to tolerate any shift as a healthcare system if it produces more infections in patients, or if it reduces efficacy of our delivered care, or if we actually, in such a low margin interest, if it costs more per patient, then it hinders our ability to provide access. But I want to suggest that these are not the case in the vast majority of single-use plastics. So if we start thinking across the board, and we, both Hardeep and I were present in an event in the fall in which we gathered stakeholders across this whole value chain, from folks working in manufacturing to regulators, purchasers and payers, clinicians at sites of use, and then actually paying attention to the effect at the sites of disposal, we can actually start thinking about ways in which there are many forms of single-use plastics that actually we could do away with without compromising safety, efficacy, or efficiency. And we have a framework to propose that.
Thank you. Can you hear me? I can shout. So one of the questions that we had prepared is, what is the appropriate threshold for implementing precautionary measures against plastics, given the current evidence of harm? So what we're asking is, how should policymakers navigate the burden of proof dilemma? Maybe Daniel, Leo, you could take one of these.
Sure, happy to. So I think a lot about the work of Sir Austin Bradford Hill, who gave this landmark lecture during the tobacco wars about the criteria for causality. He made it very clear the only criteria you really needed before you acted to prevent exposure was exposure preceding the outcome in an individual study. There were 8 other criteria, but what really was the most salient point that I think we forget is that causality is not a dichotomous variable. Causality is a continuum from 0 to 1, and it's the stakes that matter about when you decide to act. You know, I think about the Zika virus and its effect on early brain development in babies. We acted on very thin evidence to prevent the transmission of Zika virus. We have mountains more evidence for the effects of plastic on human health. And there's consistency between the laboratory and the human evidence to document that base for action. So for as much as I'm going to say as an epidemiologist, further research is needed, I can say that there's further research needed on the effects of childhood lead exposure. At the same point, we have firmly enough evidence to act. That's really what Sir Austin Bradford Hill was debating back in the day. So I'll leave it there.
Yeah. Daniel?
Yeah, I mean, I think of it different strands, but we have enough evidence to act. There's no reason that policymakers shouldn't be acting to ban single-use plastic, address all the pollution that's coming from the full life cycle of plastic. There's plenty of evidence about many of the chemicals. Actually, there's not evidence about some of the chemicals that are in plastic, but there's plenty of evidence of chemicals that are in plastic and how they affect us and how we're exposed to, enforce the Clean Air Act, enforce the Solid Waste Disposal Act, Safe Drinking Water Act, Toxic Substance Control Act. There's all these laws in place that, if actually implemented and enforced, could do quite a bit more than they are already doing to reduce exposure and I think limit the production of plastic in some ways. I had another thought about that, but that's enough. Yeah, I mean, I think we're ready to act now. Oh, the only other thing is, there's, as I said in the earlier part, there is this, the counter is from an extremely powerful, well-organized, well-funded industry. I mean, several industries, you can say, fossil fuel industry, the chemical industry, but like the chemical lobby writ large is extremely powerful and influential in Washington, D.C., both with the regulatory agencies and with Congress. And so that's a key limiter to any of this happening, and things going from bad to better or better to worse. I mean, a lot of that is the dynamic of industry power and counteractions to industry power which is what the community action, either in the actions you all are taking individually, collectively, or in conjunction with other climate and health activists around the country, around the world, that's the counter force that's going to kind of just determine the direction we all move in together.
All I'll just say, just jumping in quickly,
Yeah.
is that, I'm always interested in who the we is, right? So if we think of what we are doing, if we as Europe versus we as the United States, we have a very different set of answers, where European regulatory approaches are willing to take a more precautionary principle approach to the United States.
Yeah.
And I just want to point this out. This is one of these really, why this conversation here about climate and health is so important, because if you look at a different sphere like pharmaceuticals, right? So there's a different regulatory culture in Europe compared to the United States in the middle of the 20th century, whereby the thalidomide disaster just spread throughout all European countries, right?
Yeah.
And famously, the global reputation of the United States Food and Drug Administration is based in part on Francis Kelsey's decision not to approve thalidomide, based on effectively a precautionary principle, right?
Right.
Concerned about early results, right? So so why are we able to take precautionary action when it comes to pharmaceuticals and not when it comes to plastics? And our roles with Europe flip, and that's just a question to ask.
I mean, part of that is federal law that the pharmaceuticals, it's the burden is on the industry to prove that their product is safe and efficacious under the Toxic Substances Control Act, which is the main law for approving new chemicals. The burden of proof is on the Environmental Protection Agency to demonstrate that a chemical may pose an unreasonable risk. So the presumption is in favor of approving a new chemical and having it on the market, unless EPA gets enough information that they can make a showing that will hold up in court that a chemical may pose an unreasonable risk. And there's a bunch of other details, subparts of the law that make that hard and make it so that industry doesn't have to provide very much information to a regulatory agency with which to make a decision, whereas on the FDA side, they have to provide a ton of information. So that's one example of that dichotomy and the problem that results from that. Yeah.
Yeah, definitely a lawyer, not a doctor.
Yeah.
The next question I have for maybe Jeremy and Hardeep, given the cost effectiveness and durability of single-use plastics, what policy strategies can effectively drive a shift away from their widespread use?
So I'll defer to Hardeep for most of this, but part of this was in the diagram about the value chain that we put up, which is to say, when you look at it at one site along that chain, like just at the site of a clinician in use, or just at the site of a R&D team that's trying to figure out what product that they can actually get traction for within their company, it seems as if you're bound by a set of static laws of whether these things are cheaper or whether there's a market for it. But we know these things are dynamic, right? And so that downstream uses actually create the forces that help to shape the upstream market formations. So I think in every stage, right, we think about what JACO regulations do, what the FDA's approach can do to this, what large hospital systems can do when they actually do pooled purchasing together. Value systems that then help to drive the necessity of markets for alternatives to single-use plastics can make them affordable. And I firmly believe this is a dynamic market situation. I firmly believe this because single-use plastics were more expensive and they became affordable. So alternatives may be more expensive at first, but they can be made more affordable.
Yeah, so I'll try to get more specific. I'm thinking of policymakers broadly. So let's think of the traditional policymakers first. Of course, CDC comes to mind because they sort of govern a lot of the infection prevention guidelines. There's a lot of use of single use in healthcare because of infection prevention. In fact, most of the people outside healthcare don't want to touch the healthcare plastics because they think it's too complicated and we don't want to fight with the clinicians. And so that's why one of the reasons healthcare has been sort of left alone. So there needs to be reform of the infection prevention guidelines. And actually there is a little bit of an effort underway getting the professional societies. I know SHE is one of the biggest, infectious disease related sort of societies that is, talking about this issue now. And I think there could be movement there. FDA, there is a lot of issues with redesign that, or incentives, as you called it, for the industry. They do have about 300 items that they have said can be reprocessed safely. They give guidance, but a lot of the health systems are not sort of necessarily following that. There's also things that CMS can do. Talking about incentives, we tend to buy the cheapest stuff. So we've talked to manufacturers, and they say we produce some of these, safer products that are, either bioplastics or they're more sustainable, but there's no market for it. So we really need to create a market. And I would say then payers, I know some are around here as well, need to incentivize those products. So we're going to need professional societies, policymakers, including, I would say, EPA, FDA, CMS, and CDC on the table, and we need the professional societies to do this. All three have to work in synchrony.
Sounds easy. I know we have a lot of questions coming in through CVent, but I'm going to ask one more that we've prepared, and then we'll jump to that. What specific actions can healthcare professionals and institutions take to mitigate the health risks associated with plastics in medical settings while maintaining patient safety and quality of care?
Maybe I can start if that's okay. So we haven't talked a lot about education, and that's because, when I went to medical school in the 1990s, it was less than the time of, forgive me, Senator Frist, an open heart case. And so I think we have to acknowledge that we have a big knowledge gap, and that knowledge gap is going to require some kind of revamping of medical education to incorporate a lot. Climate's leading the way on this front. Credit to the community in that regard, but chemicals, plastics need to also be part of that picture. It can't just be air pollution and lead anymore, to be perfectly honest. So we need healthcare providers to be saying, hey, have you considered using stainless steel or glass instead of plastic? Can you look at the label? And if you see fragrance, that might be something to look away. Maybe go to the EWG Skin Deep app to reduce your exposure. Swapping out your nonstick cooking pans for cast iron and stainless steel. Heavens, please don't microwave or machine dishwasher plastic while you're at it. I've rattled those off. Those are evidence-based steps that can be implemented rapidly. And again, they don't need to require a PhD or have to break the bank. So I think really it's not just systems level in terms of how we procure, it's about systems levels in how we provide care. I mean, and one thing I want to make as an important point that's a watershed moment. Thank you, National Academy of Sciences, for putting out PFAS guidelines for clinical testing for the first time in highly contaminated communities. Because what that has done for the first time since childhood lead testing has put a laboratory medicine test for environmental exposures onto the non-occupational menu. And I suspect, and there's medical monitoring that follows that. The CDC website may not be up in that regard, but the NASEM guidelines are still out there. And phthalates and bisphenols and other chemical exposures are likely to follow. That we broke glass in that respect. So I do sense, as much as we may feel hopeless in the current climate, a lot of opportunity for energy and hope.
Yeah, I mean, I actually feel very hopeful on the practitioner front. I feel like this is something that I've only become alert to in the past few years, but along the way, I feel I keep on meeting other people who have also become alert to it in the past few years, right? Asking, why are we using all these single-use products? Why is this mountain of things at the bottom of the OR, on the floor of my clinic room or on the floor of the OR? Why are we throwing away these things that haven't even been used, but now we need to actually just toss out the door? I'm saying this because your question, Tulsi, is a really good one, and it applies both on the individual patient level, but also on the health of communities level, right? And I think that, this is one of the things history can do. I'm not going to try and convince you all to get a PhD in history or become card-carrying members of the American Historical Association. It's a great place, though. But that actually history is a useful method to actually ask, why do we take this thing for granted in our daily life? Did we always do this? Why do we need it, right? And I want to point out there's a lot of things that we've done daily for a while in medicine that have harmed people unnecessarily, right? Like daily x-rays on patients in the hospital, daily blood draws on patients in the hospital. These are wasteful economically, but they also cause harm, right? So I think we need to apply a similar metric. And it took a while for people to even ask these questions, nurses, doctors, because these things become just the taken for grantedness of our environment, our infrastructure. So to be able to apply these critical skills to all these things, all these plastics we come into contact with and say like, what good is this doing? Okay, I understand what good it's doing. Yeah, heck no, we're not going to walk away from that. But what good is this one doing? And could we drop it and replace it with others? And then you in your own institutions have tremendous power. And so I just want to highlight, let's see, I saw Deanna Benner here in the audience just a moment. Oh, there, oh my goodness, right in front. So if you haven't had a chance to meet Deanna and the work she's done in Christiana Care, definitely come up to her after talk, but really single-handedly organized a critical analysis of plastics and single-use products in healthcare, not only the way they're affecting individuals and the waste produced on the wards, but also realizing that care was actually, that material was being incinerated in Baltimore in the very incinerator that I showed you earlier, and then successfully led a drive in her own institution, researched it, found alternatives to incineration, and you signed the contract, right? Yeah. So, I mean, I just think that there's so much that is happening as individual healthcare providers are realizing this problem affects them, their patients, their communities, and we have the ability to do things just like that.
I think I'm just going to add that the reason plastics resonates a lot with clinicians is because it's very tangible. They can actually see the waste in their practice every day. They are a part of the problem and solution. And I think engaging, as you said, educating, engaging would raise the awareness. The most important thing being to make it clear that this is not anything extra that they have to do. It's a part of quality. So the more we normalize sort of the waste and sustainability related issues with plastics with the quality of care that they are delivering, the better the message will be. And I would say, how many of you have sustainability committees in your hospital or health system? How many of you have clinicians that are active on those sustainability committees? So about half of the people who raised their hands sort of said that. Clinicians need to get active in those committees. So I've heard from the sustainability people that not enough clinicians come in, and not just clinicians on the front lines who have excellent ideas to reduce waste and improve efficiency, but also the people who are in infection prevention, because they are going to be sometimes the sort of either the voice of reason or the barrier that we have to sort of cross through making changes.
Great. So we're going to turn to the CVent questions now. There's a couple of really great ones. We have about 5-ish minutes left, so we're going to try to get through as many as we can. So there's one that asks, what is the potential for bioplastics not derived from petroleum that perform well but are non-toxic and environmentally benign?
Tulsi, might you want to ask us a couple of them just to get them out there? And
Yeah. There's a fun one here. I've read over the past few years that there have been some bugs and fungi that have been discovered to eat plastics, but then I don't hear anything else about it. Why don't plastic companies take advantage of these methods? And then there's another question. Actually, let's start with those two because yeah.
Why don't I'll take the first stab I'll try to do both in one go. So bioplastics, I would love to say, are a great alternative, but they actually require greater heat to break them down and recycle them. So that is a strike one. Strike two is that they've actually done studies looking at oxidative stress and anti-androgenicity of bioplastics, and it's greater than fossil fuel derived plastics. With regard to fungi and bacteria, these are very small scale, early days. I'd love to tell you that they've got the moonshot done, but to me, they are just doing the first basic engine of getting us out of this problem. Certainly something we should invest in, but it's not clear what they metabolize to, how you deal with the waste as well. There are many issues that would need scalability that need to be worked out.
I'm just going to quickly add to do that from a scientific perspective as a researcher. To get these things on the market, you need evaluation, rigorous evaluation and robust science. And people need to understand that without robust science and rigorous evaluation, we're not going to get the answers that we need. Science is the answer.
Yeah.
Not
Here,
law, just science.
Anything else for that one?
No.
All right, I'll move on to the next question. The Joint Commission is cited by clinicians as a barrier to implementation of initiatives to move away from single-use plastics in healthcare. Is the Joint Commission involved in efforts or discussions to change this paradigm?
Don't know.
We have a representative that I'm going to pick on after this talk. Kevin, do you want to say anything? They have a new program, sustainability program, but if you have an effort in this area, feel free to chime in. Sorry to pick on you.
Microphone.
Hey, you can use mine.
Here, I'll stand next to you. Here we go. Yeah, you don't.
Sorry,
Just,
Kevin and I are friends. I'm
Yeah.
not, I mean, I can pick on him. It's okay.
So hi, everyone. Kevin Zacharias, Global Director of Healthcare Sustainability at the Joint Commission. I am their first ever. We currently have a certification that most of you probably know of. It is voluntary in nature. It does cover waste. However, obviously on the accreditation side, we are exploring what that could look like. Overall, right now, it is based on, FDA requirements from our side of things for the accreditation side. But yes, it is something we are consistently exploring, consistently looking at.
thanks.
I've talked to
Thank you.
clinicians and they will offer point to FDA because it's required by somebody else. The Joint Commission tells them, look, we're just following some other agency's recommendations. So that's why ultimately it comes down to other agencies as well.
Yeah, and it points out, and again, this is this point that both Hardeep and I are trying to bring in, which is that we're always able to point fingers in different directions when we want to not get things done in health policy, right? But the key is to actually convene the relative parties, agree on common principles, and find a way to move forward.
We only have a minute or two left. Any final thoughts? Anything else you want to add?
I have one.
Yeah.
So this may be obvious, and if it is, I apologize, but in very troubled, divisive times that I think some of us feel we're in, people hate plastic and they hate toxics in their water and in their air and in their food. And so this is a great issue to build, to speak with all Americans about. Everybody living in this country does not want PFAS in their drinking water. They don't want their kids breathing in toxic air pollution, and they really don't like plastic. So it's an opportunity to speak to everybody about these issues, and hopefully we can all gain ground together in trying to save our planet.
And I'll pause. All I want to add right now is, besides trying to convert you to the field of history, to think of how all of this is a demonstration of why what we're talking about is more than climate change, right?
Yeah.
And what we're talking about is evidence of a planetary health perspective, right? We need to be able to, by putting health at the center, right?
Yeah.
We actually witness ways which we're doing harm as well as we're doing benefit. We find ways to recommit to it, and we think about different ways of understanding the multiple crises that we're working within.
I mean, as a clinician, most clinicians I've spoken to do not realize all of the things that they're using in their daily practice that comes from plastic. When I tell them that 99% of those things that they are, using, all of the chemicals are coming from fossil fuels, they are amazed. So I think the message in fact, when we've written up papers, we couldn't convince the editors to take them and what the relationship between fossil fuel and all the gowns and gloves and things were. And we had to say, it's because most of those chemicals are coming from fossil fuel. So it's a very important message that resonates with clinicians and nurses on the front lines. And they sort of love to sort of hear that. They're already angry about the waste. You just make them more angry. So.
Yeah.
All right. Well, with that, I would like to thank all of our incredible speakers here today. A round of applause.